Let's talk about the aorta. It's the largest, most important artery in your entire body, a silent workhorse that keeps you alive with every single heartbeat. But what happens when this vital pipeline fails? Well, the consequences can be absolutely catastrophic, and today we're going to dive into exactly why.
I want you to imagine a pipeline that's under immense pressure, working perfectly for decades. Then, all of a sudden, a tear. That is the dramatic, terrifying reality of an acute aortic syndrome, and it's one of the most urgent emergencies in all of medicine.
This isn't just any chest pain. Doctors and patients, they describe it as a tearing or ripping sensation, usually in the chest or right between the shoulder blades. And it can actually move as that tear gets longer. It is literally the body's loudest alarm bell for a critical failure.
So what is actually happening here? A dissection is when the inner layer of the aorta, that's called the intima, it tears. High-pressure blood then just surges right into the wall itself, splitting the layers apart, kind of like peeling an onion. This creates a brand new false channel for blood, which can cut off blood flow to your vital organs or lead to a complete, fatal rupture.
Now, not all dissections are the same, and believe me, the location is everything. A Type A dissection involves the ascending aorta, that's the big curved part right after the heart. This is a 5-alarm surgical emergency because it can rupture into the sac around the heart or cut off blood flow to the brain. A Type B dissection, that happens further down the line and is often managed, at least at first, with aggressive blood pressure control.
Okay, so now that we've seen just how dangerous this can be, let's take a quick step back and really understand the structure we're dealing with. What makes the aorta so unique and honestly so vulnerable?
The aorta is so much more than just a pipe. It's the main highway for blood, about an inch wide where it starts. But its wall, with those 3 distinct layers, the intima, media, and adventitia, it has these incredible elastic properties. It literally expands with each heartbeat to absorb the pressure, and then it recoils to push the blood forward. It's like a crucial shock absorber, protecting all the other smaller arteries from the heart's powerful pulses.
And this right here perfectly illustrates the physics of the problem. Laplace's law basically tells us that the tension on the wall of a tube increases with both the pressure inside it and how wide it is. Think of it like a balloon. The more you inflate it, the bigger it gets, and the thinner and more fragile that wall becomes. So, and this is the key takeaway, as the aorta widens or bulges, the tension on its wall just skyrockets, making it way more likely to tear or rupture.
And that dangerous widening, that's the real heart of the issue. See, before you get that catastrophic tear of a dissection, there's often this long, silent process of weakening and bulging, and that's what we call an aneurysm.
To put it simply, an aneurysm is just a weak spot in the aortic wall that balloons outwards because of the pressure. The best analogy is a bulge on an old tire. It's a clear sign that the structural integrity is shot and that a blowout could be coming.
Now, there's a really important distinction to make here. A true aneurysm, which you see on the left, is when all 3 layers of the aortic wall stretch and bulge out together. But a pseudoaneurysm, or a false aneurysm, well, that's actually a contained leak. The inner layers have already torn, and the only thing holding the blood in is that super thin outer layer and some surrounding tissue. It's incredibly fragile.
So what causes this weakness in the first place? Well, it's really a mix of factors. The most common are degenerative, things like aging, smoking, and high blood pressure that just wear down the vessel over many years. But you also have genetic conditions like Marfan syndrome that mess with your connective tissue, and even things like infections and trauma can play a role.
But honestly, no matter the cause, the crucial point is what's happening on a microscopic level. It's this process called medial degeneration. The middle layer of the aorta, the tunica media, is literally losing its essential building blocks, the elastin and collagen fibers that give it strength and flexibility. Without those, the wall gets weak, it stretches, and boom, an aneurysm forms.
Here's the biggest challenge with aneurysms. This whole weakening process, it happens silently. They often produce 0 symptoms, until it's way too late.
And this is exactly why they are so dangerous. An aneurysm in your chest, a thoracic aneurysm, can grow for years without you ever knowing it exists. Symptoms only tend to pop up when it gets so big that it starts pushing on things nearby, causing issues like chest pain, a persistent cough, or even hoarseness.
This number is pretty chilling. For a thoracic aneurysm that grows to be larger than 6 centimeters in diameter, that's a little over 2 inches, the approximate risk of it rupturing in a given year is 7%. This really highlights why finding and monitoring these things is so absolutely critical.
So if they're silent, how do we find them? A lot of the time, it's completely by accident.
Somebody gets a chest x-ray for another reason, and it shows a widened mediastinum, basically a shadow in the chest that looks a little too big. That prompts more investigation. But really, the gold standards for diagnosis and for monitoring are advanced imaging techniques like CT scans and MRIs. They give us a precise 3D view of the aorta's size and shape.
Now, because the risk is so high on certain groups, there are some very clear screening recommendations out there. For abdominal aortic aneurysms, a simple, non-invasive ultrasound is recommended for all men between the ages of 65 and 75 who have ever smoked. It's a one-time screening that has been proven to significantly reduce aneurysm-related deaths.
All right, so once a dangerous aneurysm is found, the big question becomes, what do you do about it? And that brings us to our final section, all about modern medical and surgical interventions.
The strategy is basically twofold. First up is medical management. Doctors prescribe medications like beta blockers to lower blood pressure and reduce the stress on the aortic wall. The goal is to slow the aneurysm's growth. But then, when the risk of rupture outweighs the risk of the surgery, based on its size, how fast it's growing, or if it's causing symptoms, it's time for step 2, repair.
And there are two main ways to fix it. The traditional method is open surgery, where a surgeon literally opens you up and physically replaces that weakened section of the aorta with a durable fabric graft. Then there's the more modern, less invasive approach, endovascular repair, or EVAR. For this, a stent graft is collapsed, fed up through arteries in your leg, and then deployed inside the aneurysm, essentially relining the aorta from the inside out.
So which one's better? Well, it really depends on the patient's specific anatomy and their overall health. And here's what's so interesting. While that less invasive endovascular repair means a quicker recovery and fewer short-term complications, the studies show that over the long term, the mortality rates for both procedures are actually pretty comparable. It's a really fascinating trade-off between short-term gain and long-term durability.
And this all brings us to our final thought. The aorta is an incredibly powerful and resilient structure, but it is not invincible. We've seen how a silent bulge can lead to a 7% chance of rupture every single year. The biggest risk factors for this stuff, smoking, high blood pressure, high cholesterol, these are things that are largely within our control. The aorta does its vital work in total silence, which makes it all the more important for us to ask, are the choices we're making protecting it for the long run?